Okay, so we might get started. Welcome everyone to our third community support webinar of the year. This month's topic is on autism and chronic pain, focusing on Ehlers Danlos syndrome and hypermobility. It's my hope going forward that every year we'll have two webinars on co-occurring conditions, one on the physical side of things and the other on a more neurotype, mental type side of things. This is the first in that series tonight, and the second will be in August with our autism and ADHD webinar. If you have any suggestions for other co-occurring conditions that we should cover in next year's programming, please just let us know by sending on the suggestions to support@asiam.ie. My name is Bridget Farrell. I work for AsIAM on the community support team, so I'm one of the people that you'll reach if you call our information line. Tonight's topic is very close to my heart as I was diagnosed with being autistic back in 2020, and last year I was diagnosed with EDS on my birthday because sometimes it's easier to go to the hospital on your birthday than to try to reschedule anything with the HSE. Our speakers tonight are Kerley and Angela Mazzacco. Katie is an occupational therapist and clinical director of Horizon Therapy Services in Dundalk, and Angela is studying for her master's in education with a focus on self-advocacy for disabled adults. She also works as a teaching assistant at Trinity's Center for People with Intellectual Disabilities. Just before I let the speakers introduce themselves and we continue with tonight's presentation, I'd like to put a brief content warning at the top of the program. There'll be discussion of medical trauma as well as discussion and references to certain symptoms of EDS and hypermobility that some people might find disturbing or hard to hear. This can range from injuries and dislocations to bigger things like prolapse and even pregnancy loss. If these topics aren't something that you're comfortable with right now, but you'd still like the information provided, please get in contact with the information line and we'll do our best to provide you with a write-up of the information covered. If you have any questions during the presentation, feel free to send them in. I'll be collecting them and we'll have a 15-minute Q&A at the end of tonight's presentation. If you two would like to introduce yourself, Katie, you can go first, then Angela, and then Katie will start with their half of the presentation.
Thank you, Bridget. I actually have a little slide to introduce myself, but Bridget really did cover the majority of it. So I'm Katie, nice to meet you. I'm the occupational therapist and clinical director of Horizons Therapy Services in Dundalk, a clinic serving mostly neurodivergent children and adults. I'm multiply neurodivergent myself. I'm autistic, dyspraxic, and ADHD. And as I had mentioned previously to Bridget and Angela, I have other complexities that do not include Ehlers Danlos or hypermobility. I have chronic insomnia, migraines, and TMJ and celiac disease. We were just discussing how so many neurodivergent people seem to have co-occurring experiences. I also have sensory processing differences, which are often just part and parcel of being neurodivergent. I'm passionate about working with neurodivergent people and helping them to be the best and most satisfied version of themselves. I specialize in sensory processing and how that affects meaningful occupation. And that's me in a NASA jumpsuit, age 7, which I insisted on wearing everywhere in public for several months, and it velcroed up the back. It was not real clothes, it was a costume. Angela, do you want to introduce yourself before I go on?
Yeah, sure. So hi, everyone. My name is Angela Mazzacco. I use she, her pronouns. Like Katie said, Bridget did a great job of introducing us. So I guess a little about me personally, or why I'm involved here. So I was diagnosed with EDS at 23 and identified as autistic about 2 years later when I was 25 years old. I'm also ADHD, dyspraxic, migraines, asthma, mast cell activation, POTS, the whole lot. So really happy to be here and share a little bit about my experience. So I'll let Katie take it away.
Thank you. Before I go into the details, I do want to say that I'm not very used to discussing things in terms of like symptoms and disorders. I tend to try and use more neuroaffirming language. I'm more used to talking about neurodivergences as opposed to actual illnesses. So this can be a little different for me, and we're going to have, I guess, a little bit of medical language like Bridget said. So just before we get started, I wanted to have a little overview of what I'm going to be talking about today so that we know where we're going. So I'm going to start with a brief explanation of what Ehlers Danlos and hypermobility spectrum disorders are. I'm going to talk later on about whether they're more common for autistic people and if there really is an overlap with Ehlers Danlos, hypermobility, and being neurodivergent. I'm going to share some unreliable statistics and you'll see why they're unreliable later on. I'm going to share a little bit about the journey to diagnosis, including advocacy, knowledge, and medical gaslighting. I'm going to talk a little bit about potential harm when people don't understand or know about Ehlers Danlos and hypermobility, how they can actually cause harm, well-intended most of the time, but still harmful. I'm going to briefly touch on the mental health toll, and then I'm going to talk about how you can take care of yourself or a loved one, and then what supports you can have at school and at work to make life easier for you and help you engage in your meaningful occupations. So with that, I'm going to get started. So before I talk too much about Ehlers Danlos, I do want to just say that it's a huge topic. We're only really going to touch the surface today. I will give resources at the end about where to find more information. And Angela will be talking about the lived experience, which I do not share. So the Ehlers-Danlos syndromes, and it is a plural, are a group of connective tissue disorders. So there's 14 different subtypes, and the hypermobility Ehlers-Danlos is the most common, and apparently it's more common than all of the others put together. It also seems to be the most common one for neurodivergent people as well. So the Ehlers-Danlos syndromes affect the structure and the function of collagen most of the time, and they're heritable, which means that they can be passed on genetically, and the symptoms can vary. So they're incredibly, in terms of like manifestations in like clinical settings or just manifestations in general, they're really diverse, and there's no one typical clinical presentation, which can make the diagnosis kind of tricky. There's also, as we will see when we continue, a really big gap in terms of knowledge and knowledge sharing when it comes to these conditions. So a particular Dr. Strong on YouTube that I was watching last week talked about in med school. I'm not sure when Dr. Strong graduated, but talked about in med school how the Ehlers-Danlos syndromes were sort of taught to the students as a genetic disease that results in extreme flexibility, and sometimes there's an increased risk of a specific heart condition. And that was all. So it was kind of pitched to the students as a relatively homogeneous condition, as in it always looks the same, and that it's more of a curiosity than a serious medical condition. There was no mention of chronic pain or other organ involvement, and we know that there is. So I think that was a really interesting thing to be aware of, that this is something that is often not given in terms of information to students as they're learning. So these are the subtypes. I'm not going to go through them all. Like I said, I'm going to focus on the hypermobile Ehlers-Danlos today, but this will be available in the slides to follow up with, and you will be able to find lots of information on the other types of the Ehlers-Danlos syndromes on the information or the resources that I attach at the end of today. So I'm just going to talk a little bit about collagen because I've already mentioned it. So I've mentioned that often Ehlers-Danlos affects collagen structure and collagen production. And collagen is actually coming from a Greek word that means glue. So it's the glue that holds the body together. And in Ehlers-Danlos, this is often stretchier than expected. So there's a video from Evie Nevin, who goes by Zebra Mom on social media. Evie is autistic and has Ehlers-Danlos, and she described it as being like chewing gum instead of like household glue. So it's stretchier. So an interesting thing about collagen as well, we often talk about it when we're talking about skin and sort of skin integrity, but a quarter of our body's protein content is made up of collagen. So that is in nearly every tissue. That includes skin, muscles, tendons, ligaments, vascular structures like veins and arteries, and organs as well. So over here on the side, I have a picture of Evie Oddly, a contestant on RuPaul's Drag Race a few years ago. I'm not going to spoil anything in case anyone hasn't seen it, but Evie's able to stretch their skin out, as you can see, quite a bit around the jaw. And Evie can also push their scalp together so that it wrinkles. So there's a lot of flexibility in Evie's skin. So here I have Jamila Jamil, who also talks a lot about Ehlers-Danlos too, and she's also pulling out her skin here. You can also sometimes see in some of her pictures about hypermobility in her elbow as well. So I'm just going to move myself over here. So These are features that are usually seen across all forms of Ehlers-Danlos. So joint hypermobility is one, and that's joints that stretch further than is usual. People often talk about muscle tone, and I think there's a lot of misconceptions about what muscle tone is, especially because the fitness industry have kind of hijacked that term and implied that you can change muscle tone, but you can't. You're born with your muscle tone. So muscle tone is how much tension is in your body or in your muscles, your joints, and your tendons when your body's at rest. So it's sort of passive and partial contraction against gravity. So joint hypermobility means that your muscle tone is lower and your joints can stretch further than would be typically expected. Alongside that, we can have joint instability, and this is joints that can dislocate without major trauma. So as you can imagine, that can have a huge impact on life. Skin hyperextensibility, so that's skin that can be stretched further than is usual. Sometimes people talk about it feeling velvety, and sometimes it can be that it doesn't heal as well as you might expect. And then tissue fragility, so this is organs and body structures that are more fragile. And as you can imagine, that can have a huge impact on health and well-being. So if your collagen in your organs is stretchier than it would be expected to be, then you can have some significant difficulties. For example, blood pressure difficulties. You can also have, Bridget mentioned, ruptures as well, and there can be some heart valve difficulties too. And there can be issues where organs are not able to retain their shape. For example, a very extreme thing that Bridget did mention was uterine rupture sometimes during pregnancy, and that's a very scary thing to think about and to talk about. And then alongside this, of course, fatigue and pain is going to be a big feature because your body is going to be experiencing more trauma than another person's body might. So there are less obvious features to look out for as well. So being bendy but being in pain is one. Gastrointestinal issues is the big one. And this is one I see a lot in the clinic with children in particular, especially maybe non-speaking autistic children or non-speaking children with intellectual disability, where gastrointestinal issues are just chalked up as being part and parcel of being autistic or part and parcel of being a child. There could be severe constipation, and sometimes that can be due to gastroparesis. And often what happens here is these children are treated for constipation as in given laxatives, which actually makes the issue worse and doesn't solve it and doesn't ever really investigate the difficulty or the actual cause of what's happening. There can be bladder issues as well. The bladder is an organ, and again, it's a stretchy organ. Brain fog is another component that people often are less familiar with. The velvety fragile skin I did kind of talk about a little bit. Headaches associated with posture as well. And Angela did mention that she herself experiences POTS, which is postural orthostatic tachycardia syndrome. Angela can talk a little bit more about that because she personally experienced it. It can affect eyesight. There are sensory processing differences, particularly with proprioception, which is our sense of our muscles, our joints, our tendons, body position, calibration of force, that sort of stuff. It can also affect our sense of touch, which I didn't put there, and our sense of pain. Vascular differences I did mention, so that's going to be in the arterial and vascular structures and the heart, and that can affect blood pressure, which I've mentioned at the bottom. Flat feet is another one. Being easily injured and being exhausted. So those are things as well to look out for. So it is, like I said, a very diverse presentation. Not all of these are present all of the time, and not all of these things will mean that what you're looking at is Ehlers-Danlos, because these things can actually be part of other conditions too. So it does require quite a lot of attention and care to discover Ehlers-Danlos. So this is a graphic from a Facebook page called You Know You Have Ehlers-Danlos When. So there's a lot of signs and symptoms here, and they've used the zebra. I'm going to talk about the zebra in a little minute. So there are other things here that I didn't mention, like subluxations, osteoarthritis, osteoporosis, skin tearing, mitral valve prolapse, that's the heart condition I referenced earlier, easy bruising, fatigue, Chiari malformation, sprains, gastrointestinal issues, atrophic scarring, muscle spasms, poor healing, TMD, that's temporal mandibular joint syndrome. I actually have that myself, despite not having Ehlers-Danlos or hypermobility. It's where your jaw clicks in and out of place quite a lot. I hope it doesn't happen during this presentation, but it has been known to happen before. POTS, I did reference, postural orthostatic tachycardia syndrome, organ rupture, aneurysms, prolapse, preterm labor, irritable bowel syndrome, dysautonomia. So dysautonomia is when the autonomic system in the body is disordered. So the autonomic nervous system is things that happen automatically, like breathing, digestion, heart rate, that sort of stuff. Flat feet, swan neck deformity as well, which is a kind of an unusual bend in the fingers. I don't have it, so I can't demonstrate it. Degenerative joint disease, gastritis, arthralgia, myalgia, and surgical complications. So that's a lot, and it's a scary list. I think it's important to be aware of it, but it is honestly scary to see them all in one place together. But it's good to know what you're looking out for. So a big thing about the Ehlers Danlos community and the rare disease or the chronic illness community is zebras. And the reason for the choice of zebra being sort of like the mascot of the community is in medical school, people are often told when you hear hoofbeats, think horse, not zebra. And what that basically means is that when people come to you with a complaint or with something that they are, talking about in themselves, usually the most likely scenario is the right one. So that means that sometimes there's a tendency to jump to conclusions and think, oh, this is the most obvious thing rather than looking deeper. So it's not always a horse. Sometimes it's a zebra. And those of us who experience rare diseases are zebras. So the big question is this actually rare or is it just rarely diagnosed? So recent data says as many as 8% of autistic people also have Ehlers-Danlos syndrome. And this is kind of like, it's very unbelievable if you know a lot of autistic people or if you know a lot of people who have EDS. That statistic seems so tiny in comparison to what the actual reality is. So the autism community, we certainly seem to think there's a higher prevalence than this, and some people say it's up to 50% of autistic people are also Ehlers-Danlos. So there's a lot of unreliable information, and it's quite difficult to find good solid statistics on Ehlers-Danlos and hypermobility, especially if you're looking at an overlap with neurodivergence. There is some other information to say that neurodivergent people are twice as likely as the general population to have hypermobile joints and far more likely to experience pain on a regular basis. But hypermobility doesn't always equal Ehlers-Danlos. Many other conditions have hypermobility as a feature, and apparently around 20% of the general population are hypermobile to some extent. And there is a level that's not problematic at all and doesn't cause pain and doesn't cause any problems. It's just a little bit of extra movement in the joints. So that's something to be mindful of. Hypermobility doesn't always equal Ehlers-Danlos. So there was a 2016 study that identified that mothers with Ehlers-Danlos are more likely to have autistic children. So while that's interesting in and of itself, it doesn't really answer the causation or correlation question. And there's a good chance that maybe those mothers were undiagnosed autistic themselves. So it doesn't mean that this is a cause. I think it's more useful to look at this as something that's correlated and absolutely requires more investigation. There was also some research to say that mothers with autoimmune diseases were more likely to have autistic children as well. So there's definitely something that requires a lot more investigation here. So some early signs in children and babies. The thing is with Ehlers-Danlos is that most people discover it or are diagnosed officially in late teens or more likely adulthood. It's significantly more likely that people get diagnosed in their 20s, 30s, and 40s. So some signs to look for in children are a parent with Ehlers-Danlos or hypermobility spectrum disorder, dislocations without significant trauma, strong need for feedback through the joint. So like bending things quite far back, that's as far as my hands go. Congenital hip dysplasia, so being born with a dislocation and needing to have it relocated or having to wear a harness. Clicky joints like clicky hip. More easily hurt or injured and longer healing time than you expect. Poor stamina and easily fatigued. Pain and you maybe can't find the source. Poor concentration, mobility difficulties, and gastric difficulties. And I don't know if you can see over here, this little guy on the stool. I feel so bad in that picture because his feet are unsupported, so his core must be working so hard to keep him upright. But what you can see there is a kyphosis, so a curvature of the spine. And without his feet being stabilized, it's really hard for him to be able to get himself into a more comfortable position. You can also see the hyperextension in the knee where it goes past 180 degrees. You can also see the stretchy skin on the elbow joint. And then above that is just a little picture from Toy Story 3. All the children in that W sat, which I noticed immediately when I saw it. And W sitting, it's not exclusive to Ehlers Danlos, but it does usually indicate a degree of hypermobility. It's not unusual in very young children to W sit, but as children get older, if they can maintain a W sit comfortably, it might just be something to indicate you might want to look at muscle tone, or you might want to look at hypermobility. So what happens here is that the knee joint and the hip joint are internally rotated, and this can actually help, or not help, it can actually contribute to dislocations later in life. But a lot of children might find this position more comfortable because it offers a wider base of support and actually locks the bottom of the core in and around the pelvis so that it is a bit more stable. So if you see a child sitting like this, don't just tell them to fix their legs. I have to say, many years ago as an occupational therapist, I was guilty of this, but when you know better, you do better, and I don't discourage children from sitting comfortably anymore. So there is some talk about, is Ehlers-Danlos a spectrum? And some people believe that it is, or that hypermobility spectrum disorder and hypermobility Ehlers-Danlos are the same condition along a spectrum, and others are less sure. Others think that hypermobility spectrum disorder and hypermobile Ehlers-Danlos are separate and distinct from each other. And the thing is that it's very difficult to pinpoint anything genetic when it comes to these, even though some of the other Ehlers-Danlos may have genetic markers. There likely will be genetic markers more readily identified in the future, but currently it's still a work in progress. So it is possible that hypermobility Ehlers-Danlos and hypermobility spectrum disorder have different underlying causes, which would make them distinct from each other and from other disorders as well. So as you can see, there's a little spectrum here, two spectrums. And I like this as well when we're talking about autistic people, because, you know, sometimes people talk about the spectrum of it as if it's a line, and most of us who are autistic know that that's not what a spectrum really is. So what you're looking at is very different experiences, very different symptoms, but it's still within the spectrum of what is expected with this thing. So I just wanted, before I go into the whole experience of trying to find a diagnosis, I just wanted to touch on the work of Dr. Mary Doherty. So Mary is a consultant anaesthetist at Our Lady's Hospital in Navan, Ireland. She's actually autistic herself, and she's a neuroaffirmative researcher, and she's the founder of Autistic Doctors International. She is doing a lot of current research on barriers to healthcare for autistic people, and she's also challenging the tragedy narrative around autism, which, you know, we're here for. So one of the things that Mary has noted in her research, and this has also been researched by the University of Cambridge in 2022, Mary's research came out in January 2023, is that autistic people are more likely to experience long-term mental and physical health challenges, and autistic people report that their healthcare is of worse quality than that of others. So there's important implications for healthcare and support of autistic people here. And there's a lack of research on the health and healthcare of autistic people, especially adults. And we talk a lot about how, you know, we have long-term mental and physical health difficulties, and it maybe doesn't have to be inevitable if it's known about more, and maybe we can do more about it. So this is an interesting one when it comes to us being seen as reliable narrators of our own stories. And sometimes we're not taken seriously. And this is even more true for autistic women. Sometimes our pain isn't taken seriously. And it's extra true for autistic women of color. So, you know, sometimes when you get into marginalization, we're seen less as reliable narrators of our own stories, and we're less likely to be believed. And there's a bigger risk of medical gaslighting, and maybe things aren't explored for us. So we do need information on our lifespans. And a big thing is, are we more likely to get injured have an accident. As a dyspraxic person, I think I probably am. And as an ADHD person, I think I probably am. But this is also risky when you look at hypermobility or Ehlers Danlos and you have maybe a higher likelihood of being injured accidentally. Do we have a higher risk of stress-related illness? Are we likely to forget appointments and struggle with self-care and aftercare as we get older? I think a lot more research and support needs to be done on what happens to us as we age. So I would like to see a lot more research on our health across the lifespan, and really we need to connect the dots. There's a really good phrase in the EDS community, which is, if you can't connect the issues, think connective tissues. And that's just a graphic there from the EDS for Ireland campaign, which I have references and at the end as well. So it is important for those of us who work in healthcare to honour the whole human. And a big issue with Ehlers Danlos, hypermobility and autism is that there are different specialists and professionals involved with each. So there's rheumatologists and geneticists involved with Ehlers Danlos and hypermobility spectrum disorder. And with autism, there's more likely to be psychologists and psychiatrists, and there's occupational therapists and physios involved with both, but they're in different teams, they're in different settings, they're in different healthcare setups. So often there isn't a lot of communication or joined up thinking between the communities or between the people offering support to the communities. So this is a big issue when it comes to research and when it comes to support and when it comes to each individual's journey when they're trying to explore their experiences. So it is important that we honor the whole human. So that brings us to bodily autonomy as well. And again, this whole thing of being a reliable narrator about yourself and about your body. It's important that we have agency and power, and some autistic people struggle with this, or struggle with being enabled to have this more so. And it's important that you feel that your body is your own and you're able to make choices for you and your body. And bodily doubt is a thing that can creep in, first of all, when we're not believed about our bodily experiences, also when our sensory processing is different, and also when we are in pain and people are not buying it or people are not understanding why we're in pain. And the other thing is, pain alters your perception of your body. It alters how you feel about your body, and it alters your relationship with your body as well. So it's a big thing to experience on a regular basis, is pain. So is our mental health affected? Is mental health affected by Ehlers Danlos and by hypermobility spectrum disorders? Absolutely, it couldn't not be. So depression and anxiety are big features, and there is some research in the field of psychiatry around people who are anxious are more likely to have hypermobility. And that's an interesting thing there. Again, causation and correlation is a little bit up in the air. Another thing is fatigue, exhaustion, and burnout are all components here too. And if your body is not doing what you need it to do or what you want it to do, your ability to engage in meaningful occupations and have the life you want could be affected. And that will absolutely have an impact on your mental health. So I'm going to move on to the journey to diagnosis now, and this often doesn't occur until later in life. And I mentioned earlier, it's at least after puberty for most people, and it can be later again. It's difficult because there's a lack of resources, and there's a general lack of awareness, and there's a general lack of knowledge. Like if you go out onto the street and you ask 100 people, do you know what Ehlers-Danlos is? The majority of them will not have heard of it. Majority of them will have heard of autism, and they will know what that is. They maybe might have a misconception, but they will have heard of it. But the majority of them will not have heard of Ehlers Danlos unless they're personally affected or they know somebody who's personally affected. It affects the entire body, and sometimes the symptoms can be mistaken for other things, or they can be written off as other things, and it can take a really long time to be diagnosed. It can be hard to find a specialist. It can be hard for somebody to be taken seriously when they're describing their symptoms, and it can be hard to find a professional who can even refer you to the right specialist. So this is kind of a rough pathway to get a diagnosis. And again, I'm just going to say I'm really sorry that this isn't a smooth journey. The first step usually is to speak to your GP, and there is a chance that your GP may not have heard of Ehlers Danlos or hypermobility, in which case you may want to consider finding another GP or asking them to research it. After that, maybe you need referral to rheumatology. And then you need to be sure that this rheumatologist is knowledgeable about Ehlers Danlos or hypermobility spectrum disorder. And then are they able to or willing to assess you for this? And then a referral to a specialist in Ireland is often private, and that's the same for the UK as well. So in Ireland, there are, to my knowledge, 3 specialists. I think there are more rheumatologists who will diagnose and will assess, but I think there are 3 at least well-known specialists. I have their names at the end. So the journey to a diagnosis is often not very smooth and can often be quite an endurance for people. So this is one of the hypermobility assessments. It's called the Baton score. So this is only part of a diagnosis. This is not all of a diagnosis. So there is a 9-point score here. And if you get, depending on your age, 5 can be sort of a cutoff, but for older people, the mobility is expected to be less. So with number 1 is, can the last digit, the pinky, can it bend to 90 degrees if you push it back? For me, no. Well, no. And it would be then, can you do it on both sides of the body? That would be 2 points. 2 is, can you get the thumb back to the wrist? If you push it, I cannot even get close there. Again, 1 point for either side of the body. 3 is hyperextension in the elbows. Now, sometimes this is measured by eye, and that's not very accurate. I did plan to have a goniometer with me, and I forgot, I'm sorry. A goniometer is a device for measuring extension or range of motion in joints. So what you would be looking at here would be maybe about 190 degrees or more of extension in the elbow. And then 4 is, can you push the toes up so that they are 90 degrees to the foot? And 5 is, if your legs are extended, can you get your hands flat on the ground? So 9 would be the whole score, but anything over 5 is usually considered to be hypermobile. So another thing that I just wanted to mention, before I move on to the sensory processing differences, is that there can be genetic components. There isn't always, but there can be. So it may be helpful to have a geneticist involved as well. But at the moment, some of the genetic markers are still a little bit of a work in progress. So I did want to just touch on sensory processing differences. This is my specialty, so I actually could talk about this for several hours, and nobody wants that. I mean, I want that, but nobody else does. It's often part and parcel of being neurodivergent anyway, but it can also be part of having different feedback from your body structures. So collagen here is going to be a feature. So for example, I mentioned earlier, proprioception is feedback from your muscles, your joints, and your tendons. So that's to do with pressure, it's to do with force, it's to do with body position. So if that is different for you, then your proprioceptive processing might be different. And proprioceptive processing is something that is really involved in coordination. It's involved in refining our movements. It's also a sense that tends to make us feel anchored and present in our body. So if you're not getting enough proprioception, sometimes what happens is you seek it. And that's what I was talking about earlier, looking for strong feedback from joints and tendons, maybe where you're pushing things a lot. And you might see that with a lot of stims too. I know a lot of my stims are very proprioceptive in nature. I do a lot of putting my fingers quite far into extension. And I mean, for me, they don't go that far, but for someone with Ehlers Danlos, they would go quite far. And then tactile, so that's feedback from our skin and our membranes, like the inside of our mouth and, the eyelids, all that sort of stuff. So that's tactile. And again, collagen is part of these physical structures. And then pain, also known as nociception, is another form of sensory feedback. And that can be an intense experience if you are in chronic pain. So sensory processing differences are part and parcel of being neurodivergent, but also part and parcel of Ehlers Danlos and hypermobility. So I wanted to just touch on potential harm, and this is something that happens accidentally, I think, a lot of the time, especially with children. And these are things that we need to be careful of when we're working with children or raising children or interacting with children. Something I feel really strongly about, and that kind of frightens me, is the use of weighted items, especially for autistic children or children who are perceived to have, hyperactivity or a hard time sitting still. And weighted items, they need to come with a very serious risk assessment, and that rarely happens. And I find that so scary, especially vests. Weighted vests were initially developed for endurance athletes so that they could go harder and faster over long distances, but we seem to put them on children in the hopes that it will make them sit still. And we say that it provides proprioceptive feedback because of the weight. The only way they can provide proprioceptive feedback is if that you are actively resisting the weight, so pushing up against the weight. Otherwise, what happens is the child is getting slowly crushed. There is some possibility that it's a form of mechanical restraint as well. But what this does is it compresses the vertebrae. It can crush all of the postural joints and muscles. It can compress the lungs. It can cause musculoskeletal differences like scoliosis or kyphosis, especially if you have low muscle tone or hypermobility. So if you suspect a child has hypermobility, Ehlers Danlos, please do not put a weighted vest on them. I would not like to see any children in weighted vests, if I'm honest. Weighted blankets are another story. I have one myself. My weighted blanket is 7 kilos, and I sometimes wake up with pain in my joints from the weight of it. But I'm an adult and I can make that choice. For children, I'm not a huge fan of weighted blankets. For adults, absolutely go for it. But if you can't get out from under it under your own steam, it's a problem. So if you are going to use a weighted blanket with a child, make sure you do a full, proper risk assessment and make sure that it's not too heavy for them to handle it by themselves. Weighted laugh pads, weighted toys, those sort of things, they're different. They're not so dangerous. But there is some research from Teresa May Benson and the Spiral Foundation. She's an occupational therapist in Boston on weighted vests or weighted blankets and how they are potentially harmful for children, but absolutely fine for adults. So do your research. Handwriting demands are another potential harm for children, especially when it comes to exams or essays. And this is something I see a lot in the clinic, children who are struggling to hold their pen in a stable way without squeezing the bejeepers out of it and causing pain and discomfort in their joints, significant fatigue and significant stress. So that's something that I would often say to compensate for. Don't push it. A child who can write will always be able to write, or it's so unlikely they will lose the skill. But should they write for big chunks of time? I don't think so personally. I'm a big fan of knocking down hurdles. If you don't have to have them be there, if you don't have to jump over them, get rid of them. So, typing is a viable alternative. So is talking. Postural demands are another thing. For example, children getting in trouble for sitting in certain positions. Children need to be comfortable. So an example of that might be a child propping their head up on their hand at school and getting in trouble for sitting in a specific way, or maybe not making eye contact because their head is down. Let them at it. Comfort has to come first, and not just comfort, but like security and not being in pain. Other things might be sitting on the floor, lying down. Just postural demands can be a huge thing on adults too. I think people forget that gravity is a postural demand, and that sitting upright and standing upright are actually big demands on our posture and our postural muscles. PE is another one. It's important that if your child has hypermobility and Ehlers Danlos, that they have the option of sitting out of PE, and that time could be used for rest, not for doing something else, especially a writing task. The built environment can be another harmful thing. Is it accessible? Is it possible to get in and out of buildings? Are there steps? Are the steps narrow? Are they steep? Is there a lift? What options are there? Societal expectations as well. Things like, not letting people take rest or being annoyed when someone says they're tired and needs to go home. I talked about medical gaslighting, and I will touch on epistemic injustice just a tiny bit. I'm not going to go on too much, but I think it's important to mention. And then lack of knowledge. A lot of this harm is done because we don't know any better, or because people around us don't know any better. So the more we know, the better we can do. So I did just want to mention that children don't need to sit a certain way to learn or to play or to just do their daily occupations. Comfort and meeting their needs has to always be a priority. That has to be paramount. That has to be head and shoulders above everything else. And it's important that we allow children to determine their own comfort. And obviously, we need to allow adults with decency as well. But there is a little graphic here from one of my favorite occupational therapists, Greg Santucci. So he has a thing here about strategies for success for children. Sometimes we ask for crisscross applesauce, difficult to maintain, and it promotes slouching, and it's uncomfortable for a lot of kids. Some kids love it. I personally sit like this myself all the time, but for some people it can be tricky, and that's fine. Alternatives are absolutely fine. So maybe that involves flexible seating. Maybe it involves being able to change your position often. Maybe it involves frequent movement breaks. It definitely helps to have the feet on the floor when sitting. I showed that little guy with the kyphosis earlier and the dangling legs. So he wasn't able to stabilize his core by using his legs. So it was all core, and that's so hard to keep up with, even if you're not hypermobile. So the ideal scenario is that we let kids position themselves to meet their needs so that they don't have to sit in a set way, that they're allowed to be comfortable and allowed to feel safe and secure in their posture. So I just wanted to touch on a little bit why there are many reasons for skewed statistics. when it comes to Ehlers-Danlos and when it comes to Ehlers-Danlos and autism. So one of the big things is that Ehlers-Danlos is diagnosed more often in people who are assigned female at birth. So, you know, usually women and girls. And these people are also less likely to be identified as autistic or more likely to be identified in adulthood. So there isn't enough awareness or knowledge. And a lot of the time, there isn't communication between the professionals working with these communities so that the information isn't consolidated. It's all very separate. There's not enough awareness and knowledge, so there isn't enough research happening at all. There's a lack of specialists, and there's also more training and upskilling required for healthcare providers like physios, OTs like myself, and then also doctors in general, GPs, clinical nurse specialists. We need to upskill healthcare providers, and those opportunities need to be there. It's really hard to find continual professional development in Ehlers-Danlos and hypermobility. And if that was more accessible, then maybe more healthcare providers would know more. The other thing is, are we listening enough to individuals? The simple answer is no. We're big on evidence-based practice in healthcare, but it's often more important that we are focused on lived experience, because sometimes your evidence-based does not support what the person is telling you. And it's more important that you believe the person in front of you than that you push evidence down their throat. And lived experience ultimately will inform future evidence. The evidence just hasn't caught up to that lived experience yet. So let people tell you their stories. So on that note, epistemic injustice, I'm not going to talk about it too long, but it's a specific form of injustice done to someone specifically in their capacity as a knower. So do you know yourself? Do you know your story? Are you been allowed to know? So it's an issue of social power. So often in a scenario, it might be between patient and healthcare provider. So there's a social power imbalance there. Less so nowadays. We're getting better, I think, as a society advocating for ourselves. But there can be an issue if you have communication differences as an autistic person. Maybe it might be difficult to make sure that you're heard. Sometimes we tend to, like I said earlier, there's gaslighting involved a lot with autistic people, and sometimes our experience are chalked up to us just being autistic. It involves exclusion and silencing, so you're removed from your own narrative, and it harms people's ability to know things and to be seen to know things. So this is where the medical and social gaslighting occurs. And the picture in the background is from the Capitol crawl, which took place in the USA about 30 years ago, and was the catalyst for the Americans with Disability Act, which has also informed a lot of disability laws around the world. A lot of movement still needs to be done there. But if you don't know about the Capitol crawl, highly recommend looking into it. It is powerful stuff. And a big thing that's important is that we exist in a context. So our environment is part of our lives, and the people around us are part of our lives. So the impact of the environment is quite a big deal. So is this a barrier or is it a support to us? And the environment isn't just physical, it's social, it's cultural, and it's institutional as well. So while the physical environment can be a barrier, so can the expectations of society, so can how institutions like, for example, the HSD, the government, schools, universities, hospitals, they can also impact on us. And then cultural as well. So how are we seen? How do we treat people with mobility aids? How do we treat people who have different needs? That sort of stuff. So it's complicated. So I just wanted to mention that mobility is good and hypermobility can be problematic. So hypermobility can make it hard to find neutral resting positions, which I touched on earlier. At this point, I'm realizing that my slides are a little bit out of order, and I'm so sorry. I spent ages organizing them, and I think I did not save the right order. I tend to word vomit and then rearrange things afterwards. So apologies if this doesn't have the sequence that it should. Hypermobility can make it hard to resist gravity. We can have fatigue for being upright, like sitting and standing. And there are a lot of misconceptions about flexibility. So I've used Evie Oddly as an example here again. So Evie Oddly, like I mentioned, is a drag queen. And this is Evie Oddly here, bending backwards and walking in this position. If you see Evie perform, and some of the stuff they do is actually incredible. But you know, there's also the misconception, the old school misconception that Ehlers Danlos is just, you know, handy for being a contortionist. But then on the other side, maybe you can't see here, is Evie with a cane. And that's because Evie had injured herself in one of her performances. And Evie often is in pain and often is fatigued and often has to take time out from performing because of the impact of performing, the toll it takes on their body. So Mobility, good. Hypermobility, not so much. So, you know, the age-old stereotype for hypermobile people is, oh, you're flexible, you should do yoga. But that's a bit of a misconception. So exercising is complicated with Ehlers Danlos. It's important that exercise does happen, but significant care and caution is needed. And just because somebody is flexible doesn't mean that yoga is a good thing. It can actually cause dislocations. It can overextend joints and actually make things worse. So it is important that you find the right exercise for yourself. Pilates might be a better move because it focuses a little bit more on joint stability instead of just flexibility. So low impact exercise is the ideal. So maybe being water is good if you want to work on resistance, but again, listen to your body. For example, like long distance running isn't sustainable for anybody's body. It tends to take a huge toll on bodies. So, you know, cardio, something like an elliptical where there's less impact, or something like a stationary bike might be better. But again, listen to yourself, listen to your body. And if you can find a movement specialist who knows what they're talking about, even better, but they're not very common, unfortunately. So there are aids, accommodations and supports, and some of those might be mobility aids. So that could be a wheelchair, it could be crutches, it could be a cane, it can be lots of different things. Then there are splints and support for joints as well. Sometimes you can see really cool ones that look like jewelry to support, like especially like knuckle joints and joints in the fingers, and those can be really cool looking. But sometimes they're just functional, and that's okay too. Other things can be accommodations and tasks, so that the expectations of what the task requires is adapted to suit what you can do or can't do on that given day. An accessible environment, I mean, we can dream and we do aim for a more accessible environment as a society. And then adequate opportunity for rest and recovery as well is a very important thing that sometimes isn't afforded to people. So sometimes wheelchair users can walk, and I think that's an important thing just to mention right now, because sometimes people, I have actually heard people say about a friend of mine who was in a wheelchair one day, and an ambulatory wheelchair user, and walking the next day. This was in Dublin city centre, just outside of James's Hospital, where, you know, you would think there would be a lot of people with mobility aids. A man randomly shouted, "Oh my God, it's a miracle she can walk." Sure, that day she could walk, the day before she could not. And sometimes there's the cultural and social environment there causing barriers to people and their just their engagement in their lives. So sometimes the need for the use of mobility aids or supports or accommodations fluctuates. It's the nature of being a human being. We're not the same every day. We don't have the same needs every day. So that is from an Instagram page called This Thing They Call Recovery. So just in school, there are supports available as well. And it's important that any supports that a person uses at school or at work, that they're readily available with unrestricted access. So it shouldn't be a case where a child has to ask for their supports. They should be able to access them independently and without barriers. Reasonable accommodations for exam and schoolwork are important as well. And often that can be break times in state exams, or it can be movement breaks, rest breaks. It can be a separate exam center. It can be assistive technology, which is really important as well. That was one of the strategies I'm talking about when I'm saying maybe writing should be reduced. Then it can also mean that maybe a school bag doesn't have to be so heavy, so that, you know, you're not having that postural demand of something heavy, or the, you know, the mobility demand of having to go around to the locker and collect things. So most of the curriculum for primary and secondary school can be available online. That was true before COVID. It's even more true now. But again, aids, resources, accommodation should be flexible and tailored to the individual. They should be always under review with the individual and their family, especially in school. At work, how much you disclose is up to you. That's your choice. That's your information. Is your workplace supportive? You do have a right to request reasonable accommodations under the Employment Equality Act from 1998 to 2015. And AsIAm have a lot of information available here, and a lot of supports available here as well. And also the Work-Life Balance and Miscellaneous Provisions Act that was just out this year, you can request remote work. So I think the wording of that is quite significant. It doesn't mean that you have the right to remote work. It means you have the right to request it, not the same thing. So something just to remember as a neurodivergent person, we are potentially making hundreds more decisions a day than a neurotypical. That takes up energy and that exhausts us. And this is increased exponentially if you're chronically ill. Not to mention there's a physical toll as well. We are processing things that may be unconscious for others. And if you are physically impacted, then you're going to have to make even more decisions. So energy accounting is important, and the need for rest is important. And that brings us to spoon theory. And a lot of people who are chronically ill or chronically fatigued, and even neurodivergent people are likely familiar with spoon theory. So this is a metaphor for the amount of physical and or mental energy that a person has available for daily activities and tasks. So each day you have a certain amount of spoons. An example might be a neurotypical person with no physical disability may get up in the morning, and it might take them 1 spoon to get up out of bed. And for a neurodivergent, chronically ill, physically disabled person, it may take 3, 4 more spoons, depending on where they're starting that day in terms of wellness, emotional well-being, emotional regulation, sensory processing, fatigue, all that sort of stuff. So people without a disability or chronic health condition wake up with enough spoons to tackle the expectations of their day. And those of us with additional complexities often don't have that. So some of us might need to ration our spoons, and there's spoony communities as well. So this is an image from Neurodivergent Insights, just some examples of what might take up a person's spoons. And then I suppose the other thing is there are extra demands on your time, like medical visits or planning for your accommodations, your aids, your devices, all of that sort of stuff. So I'm coming to the end of what I'm talking about. I talked a little bit longer than I meant to, so I do apologize. I'm sorry, Angela. What we can do to change things is increase awareness and knowledge in general. It's important that healthcare providers have the opportunity to do more training and upskilling, and that when that is available, that they actually do that training. More communication between disciplines and specialists in different areas. Listen to and believe individuals when they share their stories. We can lobby the government, we do, and then share knowledge and resources as well. So here are some resources. So the Irish EDS support group is a private support group. I was talking to Anne Mix this morning, and Anne has very graciously said that people can come to the support group for support and resources and signposting in terms of where to go next. Anne was very gracious with her time with me this morning, so thank you for that. The Irish EDS Foundation as well, Anne is part of this too. Rare Ireland, Rare Family Support Network, the EDS for Ireland campaign run by Catherine Colbert. I mentioned Anne Mix already, and Anne said that people can find her on Facebook if they want to. The Ehlers Danlos Society, so they're based in the UK. They have an absolute wealth of information, highly recommend. Jenny DeBon, a movement therapist. Anne introduced me to Jenny earlier. Jenny has mobility difficulties herself, but she's a movement specialist. Ehlers Danlos Syndrome and Autism by Evie Nevins. I referenced Evie earlier. Zebra Mom, that's on the Neuro Pride YouTube channel, and the Ehlers Danlos Syndrome and Autism on Thriving Autistics YouTube channel as well. So this is just some of the specialists that you can access in Ireland. And that's me wrapping up. Thank you. I'm happy to answer questions at the end during the Q&A as well.
All right, I guess that means I'll take it away. I guess, can I go straight into sharing my screen from here? I guess I'll find out.
I don't know if that means I need to stop.
Wait. Yeah, Katie, you might have to stop sharing your screen for Angela to share her screen.
Did that work?
Yep.
I think so.
Hey. Okay, I'm going to mute myself now.
All right, awesome. So thank you so much, Katie. That was amazing. I hopefully tried to focus on really more my personal experience, since Katie has such an awesome expertise and really covered, you know, the OT side of things, which is really important. So what I thought might be helpful for folks that are here today is kind of just going through, I guess, kind of like a timeline for me, almost like my EDS and autistic life story, in the abridged version anyway. So and I hope that maybe, you know, for parents out here or for adults out here, for people of all ages, that there might be something in here that you could resonate with. So starting off in childhood and going to school, even though I've always been highly verbal, I feel like that's always been one of my skills. I wasn't, even now as a 27-year-old adult, I'm not always able to really put into words how I'm feeling. So just the vague, I don't feel good all the time, when really it was, you know, it was joint pain that was, you know, spread all over my body. Maybe it was GI issues or something, but I didn't really know how to put it into words other than I don't feel good. One of my first diagnoses was asthma. And while I do have asthma, really that came up because after running about 50 meters or so, I had to sit down on the ground. I was really winded and dizzy, and just a lot of fatigue, especially after running physical exertion and things. I've always been very clumsy, running into door frames, bumping toes, bumping fingers, and you know, tripping over nothing and things like that. Frequent sprains, especially in the ankles and things like that for me, where, you know, just walking on a flat footpath, and spraining and twisting my ankle out of nowhere. Lots and lots of GI issues since I was very small, with no real diagnosis other than, oh, just, you know, a sensitive tummy, food aversions and sensitivities for sure, but no official labeled allergies or anything like that. And in school, you know, my autistic brain taking things very literally, I learned in school, you go to the nurse when you don't feel good. So I was going, especially in kindergarten, I was going to this nurse nearly every day, because that's what you do. You said go to the nurse if you don't feel good. And so I did. And obviously I was trying to figure out so that was a thing they didn't really mean that they said, like they always do. But as I got older, I did realize that sometimes I would need to go to the nurse to just rest, and into the office. So that was, you know, really challenging for me, or even just having to leave school early, because I couldn't make it through the whole day. And like Katie brought up, one of a huge challenge for me was sitting in school, especially being one of my biggest memories from being really small in school is circle time and sitting on the floor, like Katie brought up with the crisscross applesauce, and always getting in trouble for going up against a wall to support my back. So, you know, like Katie said, just having people that are supportive and understanding and having those accommodations are so valuable. So moving on kind of towards adolescence, that was really where my symptoms, and like many people with EDS, where symptoms can become disabling and become really obvious around puberty and following puberty. So this was when medical gaslighting just became a huge part of my life. Anytime I brought it up to the GP, it was just growing pains. Eventually, once I got a bit older, it was anxiety, depression screenings, you know, but nobody really wanted to look into anything further. So I also this was when I started having a lot of co-occurring conditions as well, especially migraines, very complex migraines with different presentations, so that I would be hospitalized very often for migraines, and also for pelvic pain. I now know that I have endometriosis and I've had 2 surgeries so far for that. That was the very first surgery I had in university. And then was when I was finally identified as neurodivergent at age 16, with an ADHD diagnosis, of inattentive type ADHD. I now know with a more comprehensive assessment that it's actually the combined type of inattentive and hyperactive ADHD. But you know, we weren't given much support after that diagnosis as far as my family and everything. So even though I had that diagnosis and a little bit of that knowledge, I didn't receive really any accommodations because we didn't know what to do with it. So that's a really great segue into kind of my university experience. So yeah, I didn't really have a proper diagnosis, especially with the chronic illness, chronic pain that I was facing in university. And that transition for me into moving away from home, having to prepare all of my meals myself, having to manage a completely different schedule, took a huge physical and mental toll on my body. And that was when my symptoms really became disabling. I was in the hospital quite frequently, started to have surgeries, but still in university, I didn't have the accommodations that I needed. So I unfortunately was in a bit of a toxic program where not just myself, but anybody who was sick or injured was praised for pushing through and punished for being sick. So at one point, I had a supervisor write me a recommendation letter that they even noted how they thought it was amazing that I pushed through and was still carrying things for a stage performance while I had a dislocated shoulder. And the following year, when I was hospitalized much more frequently, he said that he would not write me a recommendation letter anymore because I'm too sick and I'm not reliable. So it was really obvious to me that that I was being punished for for my chronic illness, and I didn't have anything to label it to say, well, actually, I have Ehlers-Danlos syndrome. There's a reason for this. So moving on to that, kind of coming into adulthood where I see it at 23, I was finally diagnosed with EDS. And I'm sure as a lot of people could probably relate to, whether for themselves, their children, on their own journey for EDS, autism, ADHD. I basically figured it out myself. It was doing a lot of research online after all of these issues, and like Katie said, connecting the dots, right? That autistic pattern recognition really came in handy there. And then I was saying, there's no way that I'm having all of these symptoms and problems and there's not something that connects them. So I found the 2017 EDS diagnostic criteria and was diagnosed at age 23 at the Cleveland Clinic. I had to travel quite far from my city where I lived in the US, and had to, stay overnight, had appointments, and it was actually a cardiologist who diagnosed me, and encouraged me to join a lot of EDS support groups and things online. That was one of the best things I ever did, finding community and everything. And again, that pattern recognition and some light bulbs started going off, and went kind of on the autism journey and this a bit of the self-identification journey, which led to me seeking a professional diagnosis when I was diagnosed with autism and a proper ADHD diagnosis at 25. A huge thing that's been so important to me in adulthood is identifying as disabled. Disability is not a bad word. It's a neutral thing. I wouldn't claim that my disabilities are a superpower or anything in any way, but it's just a fact. And identifying as disabled has done so much for me. As a base level, of course, that's what you have access to by law and access to your accommodations. So as a student, as an employee, as just a human being existing in the world, the word disabled is what is in the law. But also the word disabled is empowering to me in finding my community. So in taking the huge step of moving from the US to Ireland for school, being able to connect with people here that are other disabled people, to find my community has been so incredibly important to me. So I really, really just recommend, if it's a word that you're not comfortable with, maybe start unpacking maybe what some of those feelings are behind that. Spend more time with people who are proudly disabled, join disabled people's organizations. Yeah, it's just been a really important thing to me. And it's been, important to know that what my support needs are and to receive accommodations. So my next little bit here, this is my second and final slide, excuse me, goes into a little bit about what my research is at the moment, but also what I've found to be a key piece of my EDS and autism journey is self-advocacy. This is something that I'm really, really passionate about, and has been, like I said, a key piece in getting the EDS and autism diagnosis, especially the EDS diagnosis, as professionals that are knowledgeable in this are just so hard to find. So this is just kind of a bit of a framework of self-advocacy that I've been working off of. And basically they break down self-advocacy into being four pieces, basically, these 4 building blocks. So the first one being knowledge of self. So like I was saying, in my adulthood, I was finally able to advocate for myself because I knew what my disability was. I know what my support needs are, right? So like I said, knowing a disability is not a bad word. Autism, autistic isn't not a bad word. Having these words to describe ourselves in the language that we need, and understanding your disability is so important. But also, like, just as a person too, like, what do you like? What do you dislike? What are your goals in life? Because, you know, being familiar with yourself will help you understand, you know, what you want when you're advocating for yourself. Kind of following off of that is the knowledge of your rights. So this was, of course, a huge thing for me, again, moving to a new country. While the Americans with Disabilities Act is great, it obviously doesn't apply in Ireland. But you need to know what your rights are to know even when they're being violated, right? So familiarizing yourself with the disability rights laws and protections in where you live is extremely important, I really think. And the UN Convention on the Rights of Persons with Disabilities is a really great place to start. It's a really comprehensive document and has over, I think, around 50 articles on the rights of people with disabilities. It's also available in an easy to read format. So I really highly recommend looking into that as a place to start. The third piece that I have really been focusing on in my research at the moment is communication. So kind of breaking that down, the pieces of communication can be confidence, collaboration, your body language, assertiveness. Now, right, a huge barrier, and this is where also the huge barriers to self-advocacy come up for autistic people when we think of the double empathy problem, in that 2 different kinds of brains have a hard time communicating with each other. So the weight of that miscommunication isn't all on the autistic person. It's a 2-way thing, right? And so that can be a barrier to self-advocacy, is that our communication is different. That doesn't mean that we need to be trained in neurotypical social skills, right? Another big part of that is that neurotypicals can be a bit more understanding and give us the opportunity to advocate for ourselves. But also, like I said, I am extremely privileged in the fact that I can mask, I can speak, and even with that, it took me 23 years to have an EDS diagnosis. So I can only imagine the difficulty for somebody who doesn't have that privilege. So I wanted to make sure to include the point of having access to robust AAC, you know, whatever kind of communication a person might need, and especially to communicate if they might be in pain. You know, I could only see that how much of a barrier that could be if you're not even able to communicate that you're in pain and it just being chalked down to a behavior, right? And kind of the final piece of self-advocacy is leadership. And this is not maybe an essential piece of self-advocacy because it's kind of moving away from self-advocacy to broader advocacy, working, you know, for people beyond your community and just yourself. Yeah, and that's something that I kind of have been hoping to move towards. Yeah, so that's about all I've got for the moment. I think we've got a little bit of time for some questions, and I think it looks like we've already got some available or lined up in here. So
Yeah, we'll move on to questions. So our first question that came up a few times, and I think that Angela spoke quite a bit about, and what are the reasons to pursue a diagnosis other than just knowing? Is there any change in medical care? What's actually available post this diagnosis?
Something I guess I didn't touch on with that too, that's been really important. So anesthesia, I have a lot of anesthesia complications. And that's been a huge thing to know. The difference in having surgeries before my EDS diagnosis versus after are huge. The care that anesthetists take when they know that you have an EDS diagnosis is a big difference. Same even for dental care. And again, that can kind of go with anesthesiology. Yeah, so that's been a huge thing for me. Yeah, I don't know, Katie, if there's anything else. I guess, well, and I guess like Katie said, preventing further damage, right? Like that's a huge thing. Not doing things that are risky.
Yeah, I think a big thing is knowing how to really take care of yourself. And then I'm a big fan of a lot of what Angela said there as well, about knowledge really being power when it comes to advocating for yourself. There's a lot of power in being able to name the reasons you need certain support as well. And like Angela said, sometimes there will be differences required in your care medically, even if it isn't necessarily treatable.
I'd just say that one of the reasons that I also pursued a diagnosis is that there can be a lot of complications in pregnancy, that it's better to know ahead of time if this is something that you could tell your care team, that a lot of dangers could be avoided.
Yeah, that's an important one.
Something that might come up either from Angela's personal experience or from Katie's clinic experience is, what kind of symptoms or complaints might a child have that's their way of expressing that there's some hypermobility or EDS itself going on?
I think between myself and Angela, we already mentioned quite a few of these. And I think a big one that I see is, I'm hearing this a lot from parents, is fatiguing in circumstances where you may not expect fatigue. For example, just sitting, just standing, trying to maintain a position sitting at a table, trying to maintain a position standing in a line. Another one is going for walks and complaining of pain. And Angela made a very good point that it's often written off as growing pains. But, there's a level of severity that you just don't expect with growing pains. The other one I see a lot is gastrointestinal differences or difficulties, especially constipation. And like I said, that one's often just written off as, autistic children are always constipated. Well, they're not. And laxatives can cause more harm than good, especially if there is gastroparesis in the mix. So digestive issues are one I see an awful lot mentioned and reported on here. And then the other one would be fine motor skills and weight bearing activities, where you're seeing significant extension in the joints, or where it's hard to do things that are requiring either dexterity or strength.
I would say on my end that this idea of growing pains can be talked about quite a lot, but how my growing pains, or what we thought were growing pains, showed themselves was I would wake up in the middle of the night with this pain in my legs that was bad enough to wake me from full sleep, and that might not be a growing pain.
Yeah.
Yeah, and I think just like kind of following up with that, Bridget, like I know for me, every time that I would go in the GP from ages like 8 to 16, I would say I would complain of joint pain. Nobody should be experiencing growing pains for 10 plus years.
Honestly,
time
one of the things that
doctor.
led me to a diagnosis is my husband pointed out to me that you shouldn't be still having growing pains
Yeah.
at 25. You've stopped growing.
You're done growing.
Yeah. Yeah.
And
So
I would also say unexplained stretch marks tend to be something
yes,
that would be later around puberty, but stretch marks.
No, for me it was even as early as like 6 or 7 years old. Yeah, and without any kind of weight gain or anything like that either. It was just that super stretchy, clear, almost translucent skin. So
yeah. And I suppose that on that note would be, like we said before, dislocations without major trauma, even small dislocations of small joints that you don't expect. Like, I suppose the thing you often hear about is the hip dysplasia is one thing. And Angela, I know you talked the other day when we were prepping about nursemaid's elbow, where you have a dislocation from pulling the arm, and that really shouldn't dislocate an arm. I do remember in college, one of my anatomy professors telling me, and when I looked back, I was like, oh, maybe that was undiagnosed Ehlers-Danlos, about swinging his nephew around by the arms and both shoulders dislocating. So, you know, dislocations that happen when you maybe wouldn't expect them to happen.
Another more practical one, what kind of supports can be put in place for a school for a child starting with EDS, whether that's in the classroom or in the yard for breaks?
I think a lot of support and accommodations are somewhat social and cultural for young children. So for older children, I would 100% say assistive technology is essential. So reducing the handwriting burden, but also reducing the amount of heavy materials a child has to carry around, because like school bags are no joke. The weight of them is actually frightening. When you think about on a growing child anyway, but a child with hypermobility, you're asking for like really significant problems there. So that would be one thing. Flexible seating would be something I would feel quite strongly about. I mentioned that before, allowing children to sit in ways that's comfortable for them. But that might also mean providing something different, like a bean bag, a yoga ball, a mat for the floor, just allowing children to sit in positions that are comfortable for them. Another thing is allowing movement breaks that are quite frequent, because I think people often don't realize that holding a position is difficult when you are hypermobile or when your muscle tone is on the lower end. So being able to stay upright with a postural control is quite tricky. Then other things would be if the school has, you know, multiple levels, is there a lift? Is there particular access needs that can be supported? Like, can classes be carried out on the one floor? How much traveling around during the day is there? And then rest breaks and exams, and those are categorized under reasonable accommodations by the Department of Education. There can be up to 20 minutes per state exam where a child can actually take a break. So that means they can either go for a rest or they can move around, but either way, they don't have to sit for the whole time. And then I suppose there's a scribe as an option as well, but that's a much harder option to get. And I do think some people find that as a harder thing to use as well.
Just from my own experience, I'd say I did fall victim to the victim of fashion. Definitely do a 2-strap book bag rather than a crossbody bag. I really wanted a messenger bag, but my shoulder is still in bits years after graduating.
Oh, and then there's the ADHD tendency to have to carry everything with you anyway. So your bag tends to weigh too much. Yeah. I got that too. But I suppose then also like accommodations when it comes to lockers. I know I have a lot of clients tell me I don't use my locker because of where it's located. One of my teenagers who has Ehlers Danlos said my locker is on the floor, or I've got the bottom locker. So I have to get down on my hands and knees, unlock it, and then get back up again. And that is a huge mobility issue. So this person has stopped using their locker altogether, and unfortunately is now carrying around a very heavy school bag. So we're currently pushing for assistive technology where you can get the whole curriculum on the laptop or the device. So that's a big one.
Just one other thing that I'd add to that is related to the self-advocacy piece, is there's this little zine template. It's called the self-advocacy, very clever, but it's a PDF template that you can buy and then customize, and even have your young person fill it out themselves. But it's really cool. I think it could work for truly all ages. It's not like babyish in any way, but like it could work for a 3-year-old. It could also work for a 17-year-old. But it goes through like what I like, what I dislike. Is there any super important information you need to know? Here's things that you can do to support me. So just a little tiny blurb. And yeah, it's just I think a neat activity too for kids to do, to just like start thinking about those things. So yeah.
I believe there are also school passports and hospital passports very
Ooh,
similar to
yes.
that for
Yeah,
free
yeah.
on the AsIAM website.
Oh, I didn't even know. Wow,
We've got a lot of stuff.
Another thing I just wanted to mention there was that about the flexibility and the open dialogue about supports, because support needs change. They change for anybody who has any support needs. So a big thing is that those needs should be met regularly. The young person should be able to have input, like Angela said, be able to advocate for themselves. And if if there's parental support needed there as well, there should always be that open dialogue where it can be changed to suit a person's needs. Sometimes I've given recommendations to schools and they've kind of stuck to them to the letter, never changing them forever and ever and ever. I'm like, they are recommendations. They're not a list of rules. It's more important that this person's needs are met than that you tick off everything on that list. That list is there for, I guess, ideas. Now I've included every time I write to a school or write a report that there needs to be an ongoing dialogue between the family, the child, and the school support team.
And to finish up with a broad one that I'm sure we could talk about for the rest of the night. Any specific tips for navigating medical gaslighting when you know that you're not getting the support that you need?
That's so hard, and it's so hard. And I'm saying this as a neurodivergent healthcare professional myself. I still get an awful fright when I go into a healthcare professional, and I sometimes find it hard to stand up for myself without getting argumentative. And sometimes I have to tell myself that getting argumentative is not what I wanted, but sometimes if it gets what I need, then that's okay. Not my favorite, but I think sometimes it's helpful to go in with a written list beforehand, or a list, maybe a voice note, whatever way you like to store your information. Go in with that beforehand. If you're really concerned, sometimes it's helpful to have a companion with you who is also informed beforehand. I know sometimes I find the stress of being in that situation means that I'm not listening too well. So it's helpful to have another person as well. The other thing is, if you can take notes while you're there, if you can make sure that you can reflect back on it, even to say to people, I think a very helpful thing for schools and for healthcare professionals is who is responsible for the outcome of this scenario if this doesn't go well. So make someone feel individually responsible. And I do mean that because there is sometimes a tendency to pass the buck and to say, oh, the organization is saying this, or this is the standard protocol or the procedure. So sometimes it's really helpful to say, are you responsible if this doesn't go, or if this is problematic for me, or what's the outcome if things don't go how they need to go? And then also sometimes, sadly, sometimes we need to educate our healthcare providers ourselves on our personal experiences. We shouldn't have to, but we often do.
For anybody who is who is suspicious that they may have EDS and is looking for a diagnosis, I really recommend just printing out the 2017 diagnostic criteria on the Ehlers Danlos Society website and just bringing it to your appointment. Any medical professional really should understand what's written on that, and it is truly a tick box exercise that even if they haven't heard of it, they've heard of the symptoms that are and should be able to go through it with you. Now, I'm not saying every GP could or will do that, but you could say, listen, I found this resource and it seems like it could be familiar with me. It's a shame that we have to tiptoe around all of this. And, especially us autistic researchers I would love to go into an appointment and be like, yes, this is everything I've learned. And I think I have this, and this is this. And then did you see how this connected here? And then I read this peer-reviewed research thing on PubMed, and this was just in 2019. So it probably should be pretty recent. They don't care about any of that because they'll be like, whoa, I could see somebody knows how to use Google. I've had somebody say that to me multiple times. So we have to kind of put on this performance of like, I'm sick enough, but I'm not so sick that you won't listen to me. On top of that, if it's something that you're privileged enough to have, I really recommend having like a support person in appointments with you. Just having like that extra set of ears in the room that you might not always be processing everything all at once can be really helpful. and can even just help with like your perception of like, wow, that doctor was kind of being rude. Did you think that? Or, just some, things like that. You know, in the US, I was very privileged in having just a more healthcare professionals because it's a bigger place. So I understand, here it's not as simple as like, well, just go find a new doctor. So, it is really complicated. But yeah, just keep pushing through. I don't know, and connect with people that get it. Really, that's been a huge thing for me and was a huge thing when I was first diagnosed. I really, I don't need it as much anymore, but leaning into the support groups, especially ones like Katie mentioned, or even online support groups, that was a huge thing for me, and just getting to connect with the community and see, how do you deal with these appointments? How did you manage this? There's a wealth of information and support online. So.
And can I just add to what Angela said there about having the support person there? Angela's so right about having a sounding board in another person. But the other thing is, professionals tend to be more careful about what they say to two people than what they say to one person, because that way there is two witnesses or two narrators instead of one person who can be discounted.
That's so true, Katie.
And during COVID, I wrote letters for people to say that they should have significant others or support persons with them in appointments, because it was actually happening a little more. Now, I don't think there's any reason for it, to be honest. I think it's pretty, you can insist.
Okay, so we've gone a little bit over, but there is a lot of information to cover. We'll just say.
I'm so sorry. I just wanted to add one more thing because I forgot to mention it. The Ehlers Danlos Society is having their international annual conference in Dublin this year. It's the first week of August. And the registration is a little bit steep, I'm not gonna lie, but it is a 4-day conference. I've attended it online before, and it is the information is amazing. They also have a separate program for teens and kids, which sounds really exciting. And as far as I can tell from the registration, as long as it's not booked up, that part of your registration fee is also a one-on-one consultation with an EDS expert. So that's like worth its weight in gold. So just to mention that here, I'm in no way associated or affiliated with that organization.
We're just all trying to go.
And just on that note, Anne Mix did say to me this morning that Rare Ireland have a conference in September the 30th, and that's in Athlone, and that's going to include Inclusion Ireland, Irish, Ehlers Danlos and hypermobility, also Prater Willie, Family Carers, Jack and Jill, Bumbulance, Fuss Ireland, the Irish Wheelchair Association, and more. So there's definitely, that's going to be a big one too. So I'm hoping to try to get to that, but I am probably going to be in clinic that day. But nonetheless, I will do my best, because that one's if you could go to them all.
I pasted a link to the Ehlers Danlos Society's conference in the chat in case that's helpful for anyone.
Okay, but this has been recorded. The recording will be available as soon as tomorrow morning. If you just email in, we'll send you a link, but it will also, hopefully by the end of the week, be up on our YouTube playlist. So it will be available to go back if you feel like you've missed anything. But yeah, I think that went very well. And I'm very thankful to have had you two to talk over this topic that's so close to my heart.
I'm honored to have been asked. So thank you so much for having me.
Me as well. Thank you so much.
Okay.